Hello, everybody. Welcome to the Evidence-Based Design Journal Club. Sorry we're a few minutes late, little technical difficulties. But welcome today. We're going to have a great session, I believe. I'm your host for today, Sheila Bosch. I'm an assistant professor at the University of Florida. Now, the reason we put these journal clubs together really is to bring together practitioners and researchers around specific peer-reviewed published articles, really to try and share the information that's been learned and get folks involved in evidence-based design, both practitioners and clinicians. So today, I just want to remind you that there are CEUs available. You can get the EDAC CEU and an AIA CEU. In order to access the materials you'll need, you can go to the Show My Media library icon, which is located on the top toolbar where you see that red arrow pointing. And you will have access to the AI quiz, the EDAC form, and the presentation slides from today. To download a file, just click on the green arrow next to that file, and when you're finished, click the double right arrow in the top left corner of the media library. And that library will close and the slides will refill your empty space. For EDAC credit, please complete the verification form and retain it for your records. You will need to submit that to Castle Worldwide at the time of your renewal. And for AIA credit, complete the verification quiz. You will need to purchase a CEU management fee for $10 from the Center for Health Design store and submit verification form to Shannon Recklon, and she'll upload the credits to your AIA account. And Shannon's email address is on that form. So a couple of housekeeping things. It's pretty simple. If you have questions, and please feel free to just send those in as they pop into your head, and you can just go into the chat box here, and we can see your questions. We will have some time at the end for questions as well, but do feel free to send them at any time, and we'll try to get to all of them if possible. So today we have two authors with us from this study, and first is Rose Gunn. Rose is a research associate in the Department of Family Medicine at Oregon Health and Science University in Portland, Oregon. She's involved on a number of federally funded grants looking at health system innovation and redesign. Utilizing qualitative research methods, Rose investigates practical ways clinics can improve care for patients. And Rose received a Master's of Arts in Anthropology from San Francisco State University. So welcome, Rose.
Thanks, Sheila. Great to be here.
Our second author that we have with us today is Chandra Brown-Levy. Dr. Brown-Levy received her PhD in clinical psychology from Illinois Institute of Technology in Chicago. She completed her 2-year postdoctoral fellowship at the University of Colorado Department of Family Medicine, where she currently serves as the Director of Integrated Clinical Behavioral Sciences. Through her work, Dr. Brown-Levy strives to implement integrated programs and support their development over time with regard to clinical, educational, research policy, and financial needs for growth and sustainability. So welcome, Chandra.
Thank you. Great to be here.
So hopefully everyone has had a chance to read the article for today, but it is titled Designing Clinical Space for the Delivery of Integrated Behavioral Health and Primary Care. And you can see this was quite a team effort. These are all the authors from that study. So I think we're going to have a great session. So let's just go ahead and get started then. I think it's a good idea sometimes to start with a little definition of some terms. So tell us what you mean by behavioral health and integrated care.
Sure. So I'll kind of kick us off with that. Behavioral health is a term that we use to include health behavior change as well as mental health concerns and substance use disorders and conditions. So it's an all-encompassing term that we use as opposed to saying psych or mental health. It's all-encompassing, and we use that so that we can address the needs of the patients who come to the clinics in a comprehensive way. So that's how we use that term. The other term is integrated care, and this is the combining of traditionally thought of as medical and then traditionally thought of behavioral health services in one place. And sometimes that looks like bringing behavioral health into a medical setting, and sometimes that looks like bringing medical services into a traditionally behavioral setting.
Okay. Well, thank you. So with the term behavioral health care, could that even include, say, someone has diabetes and you're trying to help them improve their, eating and exercise habits? Would that count as well?
Yes, absolutely.
Okay.
It could be health behavior change, weight loss, managing diabetes, medication adherence, depression, all of those things.
Okay. I think a lot of us think of behavioral health, we just think of the psych component, but it is, I guess, a much broader term than some of us generally think about. It's probably no surprise to folks on this call, but you have shown that the clinic's physical layout actually can present some challenges, right? Why did you undertake this study about the physical design, I guess, is really my question.
Oh, that's a good question. As you said, this probably comes as no surprise to the people who are listening to this, but it was very interesting to see it actually unfold in practice. And when we originally went into the clinics, we were not intending to write any papers or look at the physical space. We just went in to evaluate integration programs in these different clinics, and once we were in there, it became unmistakable the difference of places that had behavioral health clinicians who were located on a separate floor than the primary care clinicians, or those who were all working together in a single team. And so it really just kind of came out naturally as we were doing our analysis.
Okay, so you didn't have originally architects on the research team? Is that correct?
That's correct. That's correct. When we were in the clinics, originally we didn't, but fortunately we did take a bunch of pictures, and we took floor plans as well while we were there because it became very apparent pretty early on that these were something important to look at. So, but then not long after that, we got the architect, Brianna, on board, who could help us a little bit.
All right. So talk a little bit, if you will, about integration, and why is it such a big deal these days?
So integrating behavioral health and primary care is kind of a natural marriage. I think that there's some papers that have been written even, as many as 20 or more years ago, where primary care basically became the de facto mental health system and has been for quite some time. Oftentimes, people will come to primary care first and foremost and really will never go anywhere else to get any type of mental or behavioral needs met. And so it made really good sense to start trying to figure out how to bring behavioral health services into primary care settings, and then vice versa. There are some people who really prefer using the mental health system, but then their physical needs were going unmet. So sometimes we go back and forth, but it becomes the most effective approach to taking care of the whole person when people can go to one place and get the majority of their needs met. So that's basically our driving force, is to meet people where they're presenting for care and being able to do that as efficiently and effectively as possible.
So Chandra, you're a clinician, and I'm just curious, how has this integration been received by in the clinics that you've been to and studied?
I think that most people at the beginning, they really think it's a great idea. They're really on board. They know that the support is needed. But then when you actually start getting down to the nitty-gritty of getting people to work together, it's really challenging. And, oftentimes people come from different training backgrounds. They have different ideas of treatment approaches. How long should a visit be? What is the flow of the clinic? And so sometimes trying to get people to work together well without stepping on each other's toes can be challenging. So, great intentions, but then actually getting it to work well, it's a big culture change for both sides. So oftentimes they'll say, primary care, you got to slow down a little. Mental health needs to speed up a little. So there's a pacing issue. The language is different. There's a lot of kinks that need to be worked out to make it work well. I'm lucky to be in a clinic where we've gone through a lot of those growing pains. I wouldn't say any clinic has it perfect yet, but I think that if you go into it knowing that you're going to have some of those, it makes it a little bit easier when you are confronted with them. So lots of communication, lots of miscommunication, meetings, hopefully not too many. But there is a huge culture change component to integrating care, even though everybody has the best of intentions. So we have to be aware of that.
Mm-hmm. So this particular study here, what was the driving force really behind it?
Yeah, it was interesting. I was thinking about that as I was preparing for this. So I guess the big overview of it is that there are some really great researchers in the Department of Family Medicine at OHSU, Oregon Health and Science University here in Portland, Oregon, as well as in the University of Colorado at Denver, and they have worked together very closely on a number of studies looking at implementation, evaluation, and integration. And this group of folks for these studies was led by Debbie Cohen from here at OHSU and Larry Green and Ben Miller in Colorado. And it's a group of folks that are just very passionate about healthcare innovation. And it's just been I think Chandra might be able to speak more to it because you've been on the team for a little longer, but it's a really good group of researchers who feel very passionately about integration. And so these studies, which I'll talk about a little bit more later, really got into we're looking at what's working and what's not working in integration to kind of help out some other clinics who may be starting out.
Okay. Now, I think I was thinking we had a slide about the, sorry, I might have messed this up here, but I thought we had one showing the, sorry guys, showing the different team members and the architect, but maybe that comes later in the slides. So let's just go ahead and jump right into the method. You used a very qualitative approach, which I think is really good for getting a nice, rich, sort of dense data. And I'm sure you probably had a whole lot of data. So talk about a little bit about what did you collect, and then how did you analyze it?
Sure, yeah, and I apologize, Sheila. I actually played a little bit with the slides yesterday, so I moved things around, so there's more to come. But yeah, you're right in that qualitative researchers do not do brevity. There was a lot of data, a lot of documents that included observational field notes that we would take while we're in the clinics, photographs, as I mentioned earlier, interviews with key stakeholders. And then the analysis piece, which took quite some time, was conducted by a big group of people from different disciplines to discern the effects of these practice spatial designs on integrating care. So,
what different disciplines do you have on your team?
Pardon?
What are the different disciplines? What were the different disciplines that you had?
Gosh, let me think about this. There was clinical psychologists, there were medical doctors, anthropologists, sociologists, there was a psychiatrist at one point, Communications expert. Let's see, who am I missing? Chandra's a psychologist.
Biostatistician, epidemiologist.
Yeah, that's right, epidemiologist.
Yeah,
quite a large team then.
Yeah, it was great. I mean, I think having it was really interesting. I think having so many different disciplines, people really brought a lot of different perspectives to the table, and it enriched the analysis process. So I thought it was very worthwhile.
So in your paper, I know you mentioned that you used Atlas TI for some of the data analysis and the management of all that huge volume of data. Could you tell just a little bit more for viewers who might not be familiar with that, what that's about?
Yeah, certainly. So Atlas TI is a qualitative analysis software program, and it's an interesting kind of kooky program that we use for storing. So we store these primary documents that are usually in Word, or you can do PDFs as well. And those were our field notes and our observations. You can even put photographs in there, like we did with this particular analysis process. And that program is just really a way for us to attach codes to data as we are reading through the data and finding themes and helping us uncover little pieces that we might not have seen otherwise. So it's just kind of a way to help us track what's happening in the data. I can go more into the analysis process later. But that program is the one that everybody uses here at OHSU in our department.
All right. Well, thank you for that. So the setting, you had 19 clinics, if you will. Tell us a little bit more about those clinics and how those specific ones were identified for inclusion.
Sure, Sheila. So if you'll see here on the map, there were 19 clinics. In some of the states, we had numerous clinics. Particularly Colorado. That's where the majority. I think we had 11 practices in Colorado. So the sample for the study was 19 practices. They were selected because they were integrating care. So 11 of them, as I mentioned, were in Colorado, and those practices were participating in the Advancing Care Together project, otherwise known as ACT. And that's what we called it. So it's an initiative that really focused on practices that were actively working to make the transition to integrating care. And then there were 8 practices that were located all over the U.S., and they participated in a study called Integration Workforce Study. And in Workforce, the practices were picked by an expert panel, and these practices were a little further along in their integration experience, so they were exemplars in the United States. And the patient population for all these clinics really varied between practices, but generally speaking, these were adult patients seen in these primary care clinics.
And what I think is really awesome about these different sites that you chose is that they represent small clinics and large clinics, and some were primarily behavioral health that integrated primary care, and primary care that integrated behavioral health, and you really have a good diversity, it seems.
Yeah, I think with integration, there's no one size fits all. I mean, there's just people go about it in very different ways, and there's lots of different models, and I think there's just a variety of options that clinics have when they're integrating care.
I'm sure you probably saw a lot of different types of physical environments, too. Some better than others.
That's true. That's true.
Here's that slide I was looking for earlier that talks about your partners. This was externally funded, this research, but you did mention the physical design piece wasn't originally a part of it. Tell us a little bit more about your partners and folks.
Yeah, sorry. Yeah, it's funny now we're talking through this. It does seem like it makes more sense to move it more to the beginning. But so yes, as I mentioned earlier, so ACT, which was the one that was located in Colorado. So that was an initiative funded by a foundation called the Colorado Health Foundation, and those were the practices that were a little bit newer to integrating care. And then the workforce study was funded by 3 different agencies, ARC, the Agency for Healthcare Research and Quality, Cal MHSA Foundation, and the Maine Health Access Foundation. So those were our funders for these projects. The research teams were located at Oregon Health and Science University, University of Texas, and University of Colorado primarily. And I did definitely want to give a special shout out to Brianna Smeds, who was the architect who participated in the analysis process on this, and she is located here in Portland with PKA Architects, and she solely works on healthcare design. And then our IRB oversight, which is like our compliance oversight, is provided by all of these different institutions as well that we work with. So, yeah, lots of really, really wonderful people. And we worked, as I mentioned before, under the principal investigators, Debbie Cohen, Larry Green, and Ben Miller.
All right. Thank you for that.
Mm-hmm.
So I really like the approach that you took. It seems, well, just tell us a little bit about how you went about collecting the data. How much time did you spend at each site? Those kinds of things.
Sure, Sheila. Well, so we went on clinic visits, and between 2 and 4 experienced researchers would go to these clinics, and the visits lasted between 2 and 4 days, kind of depending on the size of the practice. And when we were there, we were really focused on intensively observing all aspects of clinical operations, and so that included any kind of teamwork areas. We shadowed clinicians when they were in their visits with patients based on, if the patient said it was okay, we would go into those visits. We just generally shadowed primary care and behavioral health clinicians, and we took notes, field notes, and they were later we wrote those up as detailed field notes. We also conducted semi-structured interviews with key stakeholders. I'm trying to think of all the different people. There were, in addition to the behavioral health clinicians and primary care clinicians, we talked to medical assistants, clinic administrators, office managers. And then additionally, we took photos of the external facility and the inside of the practice and collected floor plans as well.
Okay. So did you feel like that couple 2 to 4 days was about the right amount of time for what you were looking for?
Yeah, that's a good question. I think most of the time we did. There were a couple instances where maybe a behavioral health clinician had the flu and wasn't there, and if we were traveling across the country, it's like there's not much we can do about that. So we were sort of it was unfortunate on those particular occasions, and we just ended up having to go back. But overall, we felt like that was a good amount of time to be in the clinics.
So once you gathered all of this voluminous data, what did you talked about the Atlas TI and how you did it. What else did you do in the analysis phase?
Sure. So this is I don't want to talk about it too long, but there was a lot of different steps that were involved in this process. So we had our team, the multidisciplinary team, and it was truly a group effort, most definitely. So we first examined the photographs from each practice while we were reading field notes and interview data in Atlas TI. And I think, like most people, it's really helpful to have the photographs there when you're reading the data, because you can talk about what the physical space of an exam room looks like, but it's really difficult to, I think, sometimes envision what it really means until you have a photograph. So we were looking at the photographs as we were doing that, and I think that process really helped us understand, get a sense of the physical layout of the practices and how all the clinical teams use the spaces to deliver care. And then next we looked at these findings across practices to identify the common patterns regarding the use of physical space. And as we were working through that, we identified 2 common practice layouts, which we'll look at in a bit. And within each of the layouts, we examined how integrated care team members work together in their space to deliver integrated care. And the third step, if you'll see here on the screen, we counted instances of care coordination. So it was nice to be able to go through our data, and this is a big part of where Atlas TI came in, the software program we use. So what we did is we counted the number of times that we observed primary care clinicians and behavioral health clinicians working together face-to-face to coordinate and integrate the care for their patients. So it was very complicated, but by using Atlas, it made it much more helpful. But we were able to track each individual patient by creating a unique code for that patient, and then we applied it for every time that patient was mentioned in the field notes. And then we also had codes for the providers as well. And so we were able to kind of track every time the provider touched a patient. And once we did that, we kind of gathered all of our preliminary findings, and we shared that with Brianna Smeds, the architect. And she provided us some additional insights into the design features we were observing. And she really helped us identify some design strategies that could be employed by practices who are maybe remodeling or building a new space to deliver integrated care.
And I know we will be getting to those specific strategies here shortly.
Yeah.
So this does bring us to sort of the finding and conclusion section. So you with the help of Bria, found these two different kinds of layouts. Could you explain both of those a little bit?
Absolutely. Yeah. So there were two layouts emerged, general layouts emerged across these practices. And this one that we're looking at here, let me see if I can get my cursor to there we go, to show this. So this is layout type 1, and it had separate offices for PCC's primary care clinicians, and then down here is a BHC behavioral health clinicians, and these two providers had separate offices. And then you see here there are pods for the medical assistants, the MAs, and then they worked in these exam rooms. And so there's a bunch of variations on this model. I mean, the BHC could be located on a separate floor entirely, but it's really the hallmark of this type of layout is that everyone basically has their own office.
So this is more of an isolated kind of layout.
Absolutely, yeah, more of an isolated layout, yeah. Oops.
Looks like we have some images here.
Yeah, so I'll preface this by saying we are not photographers. We are not professional photographers, but I snagged these and stuck these on just yesterday because we have some pretty we do follow a very strict set of regulations through our institutional review board. So there's not a lot of photos that I can actually share with you because some of these practices are we need to keep them confidential. But this is one practice that let us take some photos after hours. And so this is just kind of an example, and it's a little hard to tell in these pictures, but the way that this would work is that patients would check in at a primary care clinic downstairs, and if they were going to be seen by the primary care clinician, they would go into one of these exam rooms, which is where my cursor is. This is what the exam rooms look like. And then if the primary care clinicians determined if the patients had a behavioral health need, they would send them upstairs. So they'd come up to the elevators and come out the door and wait in this area right here, right next to the elevator, to be called back to be seen by a behavioral health clinician. And this is a behavioral health clinician office right here on the left. So it's kind of a very isolated setup for sure. So
I guess then the layout too is on the other end of the spectrum from that, right? It's much more
open, absolutely. So yeah, sorry, Sheila, I didn't mean to interrupt.
No, go ahead.
So yeah, so layout 2 is a little. It's a little different, as you can see here. You'll see that the primary care clinicians, MAs, and the behavioral health clinicians are all located in one pod, and they see patients in exam rooms right here. That's sort of considered one pod. And then these both share a flex space. We saw this in a number of places. And a flex space could also be called a talking room, or it's kind of like an extra room that they would use to have maybe private conversations with other clinician-to-clinician conversations. They could have maybe see families or patients when they were done in the exam rooms and they needed to use the exam rooms for the next patient. It was just a way that people could use that room, clinicians could use that room for a variety of purposes, or do quiet heads-down work. They would have workstations in those rooms as well.
Okay, so it has a variety of furniture. It doesn't have an exam table, but it has maybe a desk or workstation, and then maybe some comfortable seating, perhaps, to encourage conversation between clinicians and family or patients. So it does sound like there's a whole lot. I think flex space is a really good term for that because it's very multi-use, isn't it?
Yeah. Certainly, yeah, and I posted a picture of one of those flex spaces in the next slide, and there's a workstation there. So on the right-hand side, this is one of the talking rooms or flex space, and there's a workstation, and we observed clinicians going in here to do some documentation in the electronic health record. Occasionally they'll see patients in here, as you can tell by the otoscope and other machinery on this wall. I'm not a clinician. I don't know what all that stuff is, but these, and then some chairs and carpeted. It was just kind of a basic room, but not quite like the exam room. And then on the left, you'll see this was one of the pods where the BHC primary care clinician and MAs shared this office space.
Looks like a fairly modern space there that you've shown. Yeah. So you have a couple of really important, I think, key findings about the physical layout and the impact. What did you find?
Sure. Yeah. So these these two key dimensions that came out of our analysis, and we found that private space and shared workspace are both very important for integration. So these two dimensions had really clear implications for how well clinicians from different professional backgrounds were able to work together to provide integrated care. So the shared workspace promotes close proximity between providers. So there was a lot of interprofessional work, increased situational awareness, enhanced capacity for on-the-fly communication, and what we refer to as bumpability. So the ability to bump into one another. And then private space, I think probably we all can empathize with this, but when you're in that kind of an open space, there's a need for a really quiet space to do some heads down work. So this need for having a private space for focused work, see patients, consult with other clinicians and staff is also very key.
Like design, it's always this sort of intricate balance between these, seemingly opposed kinds of constructs, like privacy versus visibility, or here it's private space versus shared, and it's really tough, I think, for designers to really strike the right balance between these. So thankfully, I know you have given us some of your insights, and we'll look at a couple of those floor plans here in a few. But what were your general conclusions?
Sure, yeah. So mainly that physical space can either hamper or foster the integration of primary care and behavioral health, and really we're hoping that data from these integrated care environments that we observed can provide information that practices can use to design clinical space. And I think this is something that Chandra's really good about talking about, since she sees this on an everyday basis and knows the struggle that goes with the balance of these problems.
Yeah, I'm in clinic now, so I'm in one of those kind of hybrid workspaces it's actually a shared private space, if that makes any sense, but it's kind of a quiet workspace where I could actually complete this webinar and put a little sign on the door so that I wouldn't be interrupted. But it's always trying to figure out what is that balance. Earlier today I was in a even more shared workspace. It's more interdisciplinary. It's our precepting room, as we're a residency practice. One of the practices I'm in is a residency practice. So we have pharmacy in there. We have our family docs that are attendings. We have our trainees and residents, psychologists. Sometimes we have the nurses coming in, care managers. And that's a space where everybody goes to put their heads together around cases. And it was basically as soon as I got in there, it was like, oh, can I talk to you about something real quick? So that's a place where if you want to get more work, you can go into that space, and it's very easy to be visible and to coordinate with one another, and it's that high transparency, high visibility space where a lot of, I think, the magic of integration happens. So I love having those shared spaces. It really helps get teams to synthesize and work through some of those cultural issues, and at the same time that you absolutely need that to do this work, I also need spaces like this so that I can, write my notes, and, we need those exam rooms so that we can see patients, and we kind of need all of these spaces. So if I was in the precepting room all day, I'd probably have a lot of great conversations, but I wouldn't get much documentation done. So it's always striking that balance between needing those quieter spaces, but then also being highly visible so you can truly do integrated work. I think in the first example that Rose showed, that's kind of more what and Rose, you can correct me if I'm wrong here, but I think that's more like what we think about when we have more of a co-located service, where we have people who are working all together, but it's kind of like, this is my space and that's your space, and I might transfer a patient from my space to your space, but we're not going to really be working together so much. We'll be working together but separately. Whereas when we have these combined spaces and you're having those conversations with one another, it really moves more from co-located to integrated care, and that is a very satisfying way to work with patients and other providers.
Thank you. I think we have the floor plans coming up, perhaps. Oh, not quite yet. Sorry, but we are going to talk about some of the. Obviously, every study has limitations, time, and funding, and other resources that are a problem. But we have some questions that have come in, but I'm going to hold these until we get to those floor plans, and I won't forget you all. I promise. So we'll get to those in just a few. So, from this, what do designers need to take away from your study? When designing for integrated care, our findings show that it's striking an appropriate balance between private space and the needs of private space and proximity between staff is really important. And, when a practice moves to an integrated model, they often bring new professionals into an existing practice to provide expanded services. And, we'd often see places where they would put a behavioral health clinician into a broom closet and repurpose that room, which has both. Well, there's both good and bad parts to that. But it's interesting. Because practices really use several approaches to modify their existing physical space. So, like I said, reappropriating other kinds of functional space that they had, moving clinicians into areas of high clinical workflows, locating clinicians in shared offices. And another strategy was that behavioral health clinicians would just carry their laptops around with them and get in the middle of the hustle and flow of the office. So there was really a variety of options that folks have, and design
implications. But I think regardless of whether or not you're building new facilities or remodeling, I think we worked with the study architect to come up with some space designs that might be helpful for practices when they're integrating physical and behavioral healthcare teams.
So here's what's next.
Yeah.
But before we go on, we did have a couple of questions come in I'd like to go ahead and address now. One is whether and this is probably for you, Chandra, are we to assume that the behavioral health visits typically occur in an office or the talking rooms, or do they occur in exam rooms from time to time? Where do those occur mostly, the behavioral health?
So it really kind of depends on the model that the clinic adopts in terms of integrating behavioral health and primary care, but those can happen anywhere. Sometimes they can absolutely happen in exam rooms. So sometimes a primary care provider could be seeing a patient and the presenting complaint could be toe pain, but then when they really get into it, they realize maybe somebody is having difficulty, managing their diabetes regimen, and so they bring a behavioral health provider in to help them with that, or there's a comorbid depression concern, and so they could bring that behavioral health provider right into the exam room. If their workflow does not allow for that, then that patient could be moved into a shared workspace. So usually the behavioral health providers that are doing this kind of work are pretty flexible in terms of how they work, which is why Rose said it's both a good thing and a bad thing that you can be in a broom closet. Usually you can make that work, although it doesn't necessarily feel good to be put in the broom closet. So I hope that answers that question.
Yeah, I think it does. What about the HIPAA requirements? How do you handle those in some of these flex spaces? I would imagine you would have just one patient in there at a time, perhaps, and I would imagine the flex room could provide this provider-to-provider sort of communication to keep the patient information a little more private. But how is HIPAA compliance really achieved in these integrated care clinics? With these new kinds of spaces.
If there is a care team, obviously only people who are part of that care team are going to be accessing those patient records. But as far as conversations, we're all working in the same clinic. People, sign, they understand HIPAA, but we also, I would hope most people are pretty ethical. And so those conversations are, if there's something very sensitive, usually those conversations are had in more of a private space, with limited PHI being shared. So really just the most essential components that are needed to coordinate care without getting into unnecessary details about a person that might make them uncomfortable or they prefer not to be shared with other people who could be overhearing. I think that same concern could be happening just in a general medical clinic in a pod setting, even just between nurses, MAs, and MDs or DOs. So, we're all very aware of that. Usually try to share only the minimal amount of information that's necessary to coordinate.
And regarding that, someone else had asked about how you keep the sound, how do you mitigate sound between these sort of shared spaces and the exam rooms where the other, patients might be able to hear. And maybe what we should do is just go ahead and jump into this first floor plan, and maybe you can address some of the acoustic pros and cons of this as well. But what is this floor plan about here?
Yeah, well, before I forget to answer that question, so oftentimes in some of the clinics that were using these flex spaces and these open areas, they used a lot of like noise machines, white noise machines, and some of them, especially some of the newer buildings, had some really great sound insulation. But yeah, if you can see here, this is just an example. Brianna, the architect, made this drawing based on our findings. And so this is kind of a pod system here. And I'm sorry you can't see it a little bit better. it's pretty hard to see actually on the screen, but it's a beautiful drawing. But this is a workstation A right here, and here's a workstation B. This is pod A, pod B. And if you'll see here, the whole care team is located in kind of this open space. So we have a BHC, MA, primary care clinician, maybe there's an RN, care coordinator, and then they're surrounded by the exam rooms that they see patients in, and then we have a couple flex spaces here and there. The BHCs primarily see the patients in the exam rooms, but they also have the opportunity to use the flex space if there's no exam rooms that are available. So I would say that this layout in particular could be beneficial maybe for practices with smaller rooms who could make some modifications to an already existing MA station, and then adding the clinicians and other care team members there.
So the ratios here would be you would have sort of one behavioral health care provider, one primary care clinician, to looks like 8 exam rooms. Is that about the right ratio, you think?
Yeah, I mean, ratios are hard. I mean, that is, that's kind of what this shows. We saw places with one behavioral health clinician working with 2 different pods, and they were kind of located in the middle. But it really varied from clinic to clinic, Sheila.
Okay. We have another question, too, regarding just sort of a chain of command. And who, typically in one of these integrated care clinics, do the providers and staff members typically report to the same boss at the top, or do they have different sort of, top of the food chain for these different kinds of providers? Or is that also varied just depending on their clinic?
Chandra, you want to take that one?
Yeah, I feel like unfortunately my answer here is it's highly variable depending on the organization. I mean, we worked with small single doc practices in rural areas and then huge systems. And so, in my particular department, everybody reports to the chair of the department. But then, within our clinic, or the different clinics, we have different chains of commands. There's our medical director. And then there's my job to oversee the behavioral health integration for all of family medicine. But we kind of decide who needs to report to who based on what your charge is. But I've seen social workers reporting to nurses and vice versa. And I mean, it can get real messy real fast because this is still fairly new and a lot of people are trying to figure it out. So it's incredibly variable.
Okay. We had a question, too, about these the workstations. Are these open to the patients and clients, or are they a little more enclosed, typically?
Well, I mean, they could go either way. So these ones are open, and we saw patients walking past them, not typically through them, but they could easily walk past them. And in these cases, that we often saw screen protectors and those kinds of things to keep privacy if people had their electronic health records open and they were completing a note or something. But then there's another in the other floor plan example, you'll see that there were actually closed spaces, and we did see some of those as well. So a place where everyone can share an office together, and it's a closed office. And in those cases, patients definitely did not go into those.
We have a viewer who also asked about where the clients wait. So would you have I guess I'm assuming this is more the care core and not the reception waiting. Assume you would, or would this be room on demand kind of approach? Does the clinic typically have a waiting area or not?
Yeah, pretty much in all of these clinics, they pretty much just had one waiting area. Very, very standard, where they go in and check in and wait in the waiting room and then get called back. And then these were examples of just the care areas. Yeah.
Okay. Let's look at that second floor plan example that you provided. So tell us about this. Walk us through it.
Sure. So it's actually not a whole lot different from the other one. It's just that these two pods are enclosed in shared offices. And so we have the entire care teams kind of sitting around in this area. And I think these also have the flex spaces that we talked about before. And, these are probably, this kind of layout is a little bit better for clinics who have a little bit more space. And they can, this is actually not quite as common. This one, we saw more of the open areas, but so the arrangement of these offices allows for a little bit more visibility and bumpability, but also some privacy, just because the patients can't go into those rooms. And so for practices that have a little more space, it's a little bit better because they can accommodate the entire care team into one enclosed space.
Now, what about group therapy areas? I don't really see any here. What's sort of a typical group size, or how does one usually plan or program for those kinds of visits? Is that something you might address, Chandra, perhaps?
Yeah, sure. Oftentimes, we have multi-purpose rooms for groups. So, that could be a room where it could be reserved for meetings, but could also be a group room. In some practices that have really limited space, I've seen them hold groups after hours in the waiting rooms as well. So just kind of doing whatever needs to be done to make that work. But oftentimes, even as you see in floor plan example 2 here, it could be the staff lounge, and just using that space creatively. A lot of times, if you're lucky enough to plan for integrated care before the space is designed, then you can create spaces that would be conducive to that. But a lot of these practices are just kind of trying to make their existing space work. So oftentimes it's shared. It's not a designated group room, especially in the primary care setting.
So it's safe to say that these two floor plans don't necessarily encompass everything that would be in a program for an integrated care clinic, but it's more of the sort of the layout regarding the work areas versus exam rooms and having that flex space. It seems. So we're getting close to the end of our hour. Let's move on. We'll get as many other questions as we can when we get to them. But what were some of the limitations of this particular study that you all have published?
Sure. So really quickly, as I mentioned before, the data that we collected was that was just what was happening during the particular time periods where we were there. And then what we noticed could be shaped by the preconceptions of the research team members. We really tried to mitigate that limitation by having a multi-person data collection team and mix it up as we went out to the different sites. And so those were the primary limitations for this study.
Okay. So what is next? Have you conducted any research regarding the physical design since you've published this study, or not?
Well, one of the things that Rose and I were talking about is, kind of taking a little bit of a step back after we wrote this up and thinking about the implementation side. So, like I spoke about earlier, one of my jobs is to integrate throughout practices at University of Colorado, and so we have a variety of different things we're trying to do. One is, integrating in existing spaces where we don't have a lot of ability to modify the space, but we do have some. So using this paper and the findings from all of these practices to help inform the redesign of some existing spaces where we can't add square footage, but we might be able to be a little bit more creative in terms of how people move through the space that we do have, integrating, the design of the space with the workflow of the people. The other thing is, we have a clinic where the existing space is also being expanded. So sharing this with our architects and saying, okay, how are we going to incorporate what we have with what we can add in a way that's going to support integrated care? So that's another way we're using this. And then the third way is there's another practice where they've been in the same location for multiple decades, and this fall we'll be moving to a completely new space which will be totally redesigned. And so using this article has been very helpful in working with those architects to say how do we modify in all three of these different scenarios. So I think that as we do that, we'll continue to collect data to see, how is that working? Did it work well? Did it work better, having had this information at the beginning? My sense is yes, but stay tuned. I will certainly share that with whomever is interested as we continue to learn more.
I look forward to that. I'm going to try to sneak in one more question. I know we're out of time, but we started 4 minutes late. So the question, what about how do people react, say, when they don't have private offices and maybe they were used to having them at another place? Does there seem, because this whole idea of collaboration and getting people closer, proximity, but that sort of, oftentimes means people don't get their own private offices. So how do people react to that, just culturally?
Some don't react well. Some people like having their own space, and they're very used to, a certain routine. And so one of the things that we've learned is that this is not for everybody. And so sometimes that cultural change means turnover for some people, unfortunately. But I think what we've learned is that this is really good for patient care. It's also really good for generally lowering burnout rates for clinicians on both sides. So there are some people who really are used to practicing in a certain way, and getting them to change is not something they're interested in. But I think for the vast majority, this feels pretty good. As long as you can have that combination of shared time and then some quiet time, it usually works. But I wouldn't say it works for 100% of the people 100% of the time.
And we did have one more question come in about if they want to know more. When you have these other results in the future, how can they track or follow you folks and be sure that they don't miss out on that good data? What's the best way?
Rose,
through the center, perhaps?
Yeah, I'm trying to think.
Sure.
Yeah, I think we have a great website here at the Department of Family Medicine at Oregon Health and Science University. We have a great page about the research that we're doing, and that has links to articles and things like that. So Debbie Cohen is the person that I most closely work with, and she's the principal investigator. So I'd say just look her up, and that always has some information. And Chandra, I don't know about you.
Yeah, I'm happy to share my contact information with anybody who wants to stay in touch. The other thing is there's an ARC website, Integration Academy, where a lot of information is published, things that Rose and I have worked on, as well as lots of other people around the country and beyond. So that's another great resource if you're looking to delve into this a little bit further.
Yeah.
Okay. Great, thank you. Well, let's just do our final last-minute housekeeping. First of all, thanks to both of you. This has been a very interesting study, very interesting talk, and I really appreciate both of you for being here today. For the Q&A, we've already done that. So just a quick reminder on your CEUs for EDAC or AIA. You can download those resources that you need. The verification, remember you'll need to purchase a $10 fee from the center's store if you will be needing that AIA CEU. And we'd like to thank our partners who make this Evidence-Based Design Journal Club available and free to anyone who wants to participate. And just once again, thanks to both the authors. We'll hopefully hear more from you in the near term.
Great.
Bye-bye.
Thank you so much, Sheila. Take care.
Thank you.
You.
Bye.